Hello everyone, this is Amit Barua from Arjikor Medical College, Kolkata. So welcome to my channel. So in this video, I will talk about the anatomy, nerve supply, the development and the diseases of the external auditory canal. So watch the video till end, and for more updates, subscribe the Artistic Talk.
So let's start the anatomy. External acoustic canal. Extensive from the bottom of concha to tympanic membrane. It is 24 mm long. It has two parts. Cartilaginous part and bony part. Cartilaginous part. It is the outer 1/3 part of the canal. Directed upwards, backwards, and medially. It has two deficiencies. Fissure of Santorini. Through them superficial mastoid or parotid infections can appear in the canal or vice versa. Bony part. Its inner 2/3 of the canal. Devoid of hair and ceruminous glands. Isthmus present 6 mm lateral to tympanic membrane. Anteroinferior part of the meatus, beyond the isthmus, recess presents, called anterior recess. Discharge and debris may reserve here in external or middle ear infections. Let's discuss about the nerve supply. The anterior wall and the roof is supplied by auriculotemporal nerve. Posterior wall and the floor is supplied by auricular branch of vagus. And the posterior wall also receives sensory fiber of facial nerve through auricular branch of vagus nerve. Now come to the developmental process. External auditory meatus develops from the first bronchial cleft. At the 16th embryonic week cells proliferate from the bottom of ectodermal cleft to form medial plug. Recanalization of plug begins from the deeper part near tympanic membrane and progress outwards. The epithelial lining of bony meatus is formed through the recanalization process of the plug. It fully forms by the 28th week of gestation. Now let's take a look at the diseases of canal. Congenital diseases. There may be atresia of ear canal or coloral fistula. Atresia occurs due to failure of canalization of ectodermal core. In these cases, the outer meatus is obliterated with fibrous tissue or bone. Though the deep meatus and the tympanic membrane are normal. These occurs because the recanalization begins from deeper part and progress outwards. Atresia is also associated with microtia, which more common. Coloral fistula occurs due to abnormality of first bronchial cleft. One opening situates in the neck, just below and behind the angle of mandible, and other in the external canal or middle ear. Fistula traverses through the parotid in close relation to the facial nerve. Inflammations of ear canal. This can be grouped into infective and reactive set of diseases, on etiological basis. Infective otitis externa may be due to bacterial, fungal, or viral cause. Due to bacterial infection, localized bacterial infection, diffuse otitis externa and malignant otitis externa may cause. Furuncle or localized acute otitis externa. Inflammation of hair follicles due to staphylococcus. Patient presents with severe pain and tenderness. Jaw movement causes pain in ear. Edema over mastoid due to posterior canal wall furuncle may occur with obliteration of retroauricular groove. Systemic antibiotics analgesics are given in early cases. 10% ectamol glycerin ear pack provides splintage and reduces pain. In case of formation of abscess, incision and drainage should be done. In case of recurrence, diabetes should be excluded. All skin sources of Staphylococcus should be excluded and treated properly. Diffuse otitis externa. Commonly seen in hot and humid climate and in swimmers. Sweating changes the pH of medial skin to alkaline, which favors growth of pathogens. Trauma to medial skin and invasion by pathogen can cause this condition. Staphylococcus aureus, Pseudomonas pyocyaneus, Bacillus proteus, E. coli are common organisms responsible for otitis externa. Clinical features may be acute or chronic. In acute phase, burning sensation in ear followed by pain which is aggravated by movements of jaw is seen. Serous oozing starts which later becomes thick and purulent. Collection may cause conductive heating loss. Acute case is managed by ear toileting by dry mopping, suction, or irrigating the canal with warm, sterile normal saline. After toileting, antibiotic-soaked gauze wick is introduced. Same antibiotic is given twice or thrice a day and the wick is being changed daily for 2 to 3 days. Aluminium acetate, 8%, or silver nitrate, 3%, are used to form a protected time coagulum to dry up an oozing meatus. Analgesics given as pain reliever. In chronic phase, irritation and strong desire for itching is seen. Crust may be seen, which is dried form of discharge. Treatment of chronic case is to reduce medial swelling for better ear toileting and to alleviate itching to reduce recurrence. Gauze is soaked in 10% ectamol glycerin and inserted into canal. Itching is controlled by topical antibiotic steroid cream. Malignant or necrotizing otitis externa. It's an inflammatory condition caused by Pseudomonas in elderly diabetics, or in those on immunosuppression therapy. Excruciating pain and appearance of granulation is seen in ear canal. May spread to skull baseband, jugular foramen, causing cranial nerve palsies. Or may spread to temporomandibular fossa, mastoid or middle ear and petrel bone. For diagnosis, gallium-67 scan is useful. Reticuloendothelial cells monocytes take up the gallium, and is indicative of soft tissue infection. Treatment consists of control of diabetes. Antibiotics against Pseudomonas, intravenous gentamicin, and ticarcillin. Third-generation cephalosporin, like ceftriaxone 1 to 2 gm/day4 or ceftazidime 4 with aminoglycoside is given. Quinolones are also effective. In non-responsive patients, culture and sensitivity is being done and treated accordingly. Prolonged antibiotic therapy has replaced by radical surgery and resection.
The rest of the traumatic portion, the diseases and the tumors of the ear canal, will be discussed in the subsequent video. One important information, that videos on basic surgical skills by our respected Professor Ramanujam sir is coming very soon. In that videos, sir will show and explain the surgical skills, basic needs. So stay tuned for the videos and subscribe the Artistic Talk.